We are at ASCO. It's all about new things and new progress. We've talked about some of the high-level data that's gone forward there. Eileen, talk a little bit about where the new medicines are, what's on the next wave, some IL-10. What do we do with that?
So, and just to emphasize the point of immunotherapy, it's not that we think that there isn't a role here. I think we just have to learn where it fits and again, select the patients. So a couple of very interesting strategies are combining immune agents together and studying them prospectively in clinical trials, combining immune agents with chemotherapy. So an example of that is the pegylated IL-10, which has shown some interesting data with FOLFOX in a phase 1 setting, showing safety and a potential signal. And that's been translated into a randomized phase 3, comparing FOLFOX plus pegylated IL-10 in previously treated pancreas cancer. That's accruing well, and we'll look forward to seeing data earlier this year. And there's some nice immune data which support the notion that this could be meaningful.
So there are a lot of clinical trials going on in this space, frontline, second line, and a lot of new medicines being brought. Of course, that's been the tradition, and we've had a lot of failures, so fingers crossed there. Tony, some other studies that you're looking out for?
You know, a couple of interesting studies that are ongoing in the first line space. So CanStem 111P, essentially a study looking at an agent called nepabucicin, which is a stem cell or stemness inhibitor that, at least in preclinical study, has shown to resensitize tumor cells by holding off the stem-like cells to the effects of chemotherapy, and certainly enhance the kill from chemotherapy. The phase 1b/2 study, about 66 patients, essentially showed a response rate of 55% and a couple of CRs, quite meaningful, with a PFS north of 7 months, and actually survival in the selected patient population close to a year now, a little bit more than a year. So meaningful, although again a small study, but that led essentially to the phase 3 study with gemcitabine nab-paclitaxel plus minus nepabucicin, about 1,100 plus patients, but also has some stopping rules along the way, accruing very well. The other study is a study with nab-paclitaxel and gemcitabine and an agent called PEG-PH20, which targets hyaluronidase, stromal targeting.
I thought that study was negative with FOLFIRINOX.
Yes. So this is so there were 2 studies. There was a phase 2 randomized study that was recently published in the Journal of Clinical Oncology with gemcitabine nab-paclitaxel plus minus PEG-PH20. The study actually initially didn't reach its endpoints, and with the more exploratory secondary points picking up the high HAs, was somewhat positive, although I'll say in the survival didn't seem too much affected by the addition of PEG-20. And then Ramesh Ramanathan presented his data this ASCO GI with the FOLFIRINOX plus minus PEG-PH20, and you had to really look at those curves multiple times to make sure that you're seeing right, and they were flipped. The PEG-PH20 plus FOLFIRINOX had a survival of 7 months. I haven't seen that for quite a while.
Anybody got any idea why?
I think
You got a
there's
theory?
discussion about the cytotoxic backbone. Less systemic therapy was delivered. It wasn't a biomarker selected population, so we have to
7
learn.
months.
So when I saw
it's a
those
concern,
curves,
7 months is detrimental. I think I would argue, this goes
toxicity
back to
was
the,
worse.
understood, but I think that goes back to the argument that you have to be careful about how you handle the microenvironment, because it's both a friend and a foe, and you want to make sure that it doesn't end up killing you.
Well, we have the GEM-NAB study open at our site, and so I saw those curves, and I thought to ourselves, and we discussed as a team, should we maintain that trial based on your logic? And we did. In the end, we decided to maintain that. I have a patient on the experimental arm right now. Well, I was blinded, so I don't know.
I trust the Data and Safety Monitoring Board did their job and were very thorough and
Said
considering.
We could continue.
Yeah.
But this will be a very interesting readout on whether
That's a great point about the safety. I mean, they're more than halfway through their, 570 patient trial. There have not been any real concerns about lack of efficacy with the backbone of nab-paclitaxel gemcitabine. So yeah, I agree with Tony. That was very concerning, that 7 month. But I think a lot of it can be attributed to the FOLFIRINOX and the management and the need for low molecular weight heparin while giving treatment, all those other issues. I think it's still an important trial. The phase 2 that was presented They're small numbers, but let's see what this does. The PFS was 9 months. PFS was 9 months, so the survival should be even longer. So let's see what
Although
happens.
we don't clearly understand whether HA is prognostic or not, so we have to be careful about to interpret. Once you start going down the line of
Well, but
less
it's
and less
worth
and less and
continuing
less
the
patients.
trial, you'd say?
I think, as Eileen said, you can't argue with a DSMB that's essentially looking at the data in an unblinded fashion and taking decisions about safety and efficacy. So, what we could only guess right now is that at least there's no detriment, no significant detriment that is observed with a combination of the two drugs plus the PEG-PH20, similar to what was seen. A 7 month, literally cutting the survival by half, you can't miss that. You're not going to miss that even earlier on in the study.
95% of our patients with pancreas cancer have a RAS mutation, thought to be undruggable. And one of the most pleasant things I experienced during this meeting is lots of other meetings looking at drugs that might just target RAS. We have a dedicated task force, the NCI, and a public-private partnership looking at this, and so we're starting to see this bubble up. You see this as maybe a way forward?
I do. I think there is real optimism that this nut can be cracked in pancreas cancer, and obviously it'll be a major step when it happens. There's some SHIP inhibitors now in the clinic for the cysteine residues that look promising for patients with lung cancer. It's a small subset of people with that mutation in pancreas cancer, but nonetheless, I'm optimistic that we can ultimately address this problem.